This conference will now be recorded.
Welcome in, everybody. On today's topic, we are going to be talking about pediatric.
This conference will now be recorded.
Welcome in, everybody. On today's lecture, we're going to be talking about pediatrics and infants. Quite a few changes, especially when we're dealing with vital signs and then also pathophysiology as far as what's going on inside that body and how we can help facilitate those treatments. So when we're looking at statistics as far as peds go, over 12,000, 0 to 19 die every year in motor vehicle accidents. So this is going to be the leading cause of morbidity and mortality, especially when we're dealing with the pediatric range in between that. And then when we're looking at even our younger age, if we break it down just in between 1 to 4, drowning is actually the leading cause of injury and or death. And oftentimes these incidences actually occur within bathtubs. And then for children less than 1 year of age, 2/3 of injury are due to suffocation. So oftentimes this actually occurs when the infant's sleeping. Maybe they're not positioned properly. Maybe it's the wrong crib, excess blankets, excess teddy bears, stuffed animals, what have you. This is where we're starting to look at those SIDS statistics, and SIDS stands for sudden infant death syndrome. So vital signs, when we're looking at this, every age group is going to have a little bit different vital signs, and oftentimes it correlates to how much blood supply and what their blood pressure is as far as circulating through their system. So generally, age range over 10, our normal heart rate is going to be in between 60 to 100, which is our normal adult value. When we're looking at vital signs for our 2 to 10-year-old, because we have less blood supply, our blood pressure is a little bit lower at this point, our heart rate's got to be increased. So we're looking at about 60 to 140. Then 3 months to 2 years, it can range in between 100 to 190. And then newborns to 3 months, 85 to 205. So you see a very broad spectrum. And it's very difficult to actually remember all these different statistics when we are looking at, heart rate and blood pressure and respiratory rate when we're dealing with newborns, neonates, preschool children, school-age children, what have you. Remember, get reference cards and some other things that you can reference those. Don't beat yourself up by trying to remember all these different statistics. So when we're looking at quality, as far as pulse quality, a couple of different things can create different pulse quality. So when we're looking at rapid, oftentimes this is going to be from anxiety or pain. Crying will increase that heart rate, especially with our neonates and our infants. You could also see rapid from dehydration, blood loss, and shock. And this is going to be the first initial vital sign that we see, is that heart rate's going to increase, that pulse quality is going to be rapid. If we don't treat that at all, that patient's going to start to decompensate, then we're going to see a slower heart rate. So when we do see that slow, again, this could be from that individual going to a decompensated shock phase. We also see drugs, head injuries, poisons, some heart problems. We don't see heart problems all that often in our pediatric patient. Oftentimes this is a developmental disease process where we see that in adults from lifestyle habits. And then lack of oxygen is going to be the big one that plays into this. Respiratory related emergencies, hypoxia leading into a decompensated shock phase. And then irregular, this is going to be from abnormal electrical activity. Again, we don't see this very often because peds, infants, they oftentimes have healthy hearts. And if we don't feel that, that pulse rhythm, whether it's brachial, carotid, what have you, that means that patient's in cardiac arrest, and then we're just going to follow our CPR algorithm. So here is our respirations based on our age limit. And we can see that the younger they are, the faster that they breathe, because they need more oxygen consumption, because they are growing substantially. And then also, again, it's back to that blood supply. They don't have a ton of blood supply, and as a result, they need more oxygen to facilitate a faster heart rate. So those hemoglobin is actually bouncing around that system quite a bit faster in comparison to the adult, where blood supply is about 5 to 6 liters. We have substantial hemoglobin, and it's going to go a little bit slower, and we can breathe slower because we don't need as much oxygen consumption as we see for the infants and the pediatrics that we're going to be dealing with. Now, blood pressure is going to differ a little bit in comparison to the vital signs that we've talked about. So again, heart rate, respiratory rate, those vital signs oftentimes are higher the younger that we are, and then gradually they get lower. Blood pressure is different, and it works in the reverse. So our younger children, our infants, our neonates, and then preschool and up, it's going to start with a lower blood pressure, and then eventually over time that blood pressure is actually going to increase, because basically we have to tone those blood vessels in order to actually constrict and be able to regulate our blood pressure. And so at that current age, that systemic vascular resistance is not actually developed at that point, and that's why we see that blood pressure is actually quite a bit lower. So how we assess our pediatrics, and this is quite a difficult thing, especially when we're dealing with responders who maybe don't go on many pediatric calls, or your new EMRs or your new EMTs tend to have difficulty with this. But remember, they display a lot of the same signs and symptoms as their adult. Go ahead and be confident and treat them. And a great tip to use is this pediatric assessment triangle. So this is going to kind of formulate our general impression when we're talking about dealing with a patient assessment. So when we walk into the room, these are the three big categories that we're looking at: appearance, work of breathing, and circulation. So appearance, this is going to be our mental status, how that patient is positioned, and then also their muscle tone. So if I walk in and that 2-year-old, that pediatric patient immediately looks at me, they're tracking me, okay, good. That's good mental status, they're tracking me. Now, if I walk in and there's something wrong with that appearance right off the bat, maybe they're flaccid, maybe they appear to be unconscious, what have you, okay, I know immediate intervention needs to be performed. And if I see anything wrong with the appearance, the work of breathing, or the circulation, I know right off the bat, okay, immediate intervention is required at this time. Next, I'm looking at that work of breathing. So can I see good chest rise? Or, with our younger individuals, they predominantly are belly breathers. And then do I hear anything as far as audible sounds? Wheezes, stridor, crackles, rails right off the bat when I walk into that room. And then next is circulation, especially babies, pediatrics, oftentimes you can see good color right off the bat. And when they start to get in trouble, that color changes pretty dramatically. So look for those signs of cyanosis, pale, ashen color. And again, be ready to intervene if you see anything wrong within this pediatric assessment triangle. So some assessment tips when we are dealing with this. Again, we are going to be going over the same steps that we do with our with our patient assessment, only we're going to tailor in some of these tips. We're also going to tailor in that pediatric assessment triangle. So when we do approach our patient, approach slowly, because you don't want to scare them at all. And especially when you start dealing with school-age children, they are taught the stranger danger aspect, and they might be scared and or intimidated by you. Establish eye contact from that safe distance and begin to build up that patient rapport. Get down to their eye level, because if you're towering over them, they're going to perceive you as a threat. So again, get down to their angle, and that's going to create that relationship between the EMS provider and then also that patient. If you can, let that parent stay with that patient. If aggressive airway treatments doesn't have to be established, or CPR or anything. Now, if you're assessing that patient and they're alert and they're tracking and they're breathing okay, let that mom or let that dad continue to hold them, because you create that comfort care level. Now, if child abuse is suspected, this is where you want to get law enforcement involved and then go ahead and separate that parent from that child. Quickly determine if there is any life-threatening emergencies. So patients, pediatrics and infants, they compensate really well, but they don't compensate for very long. So if you don't establish those immediate interventions that are needed, they're going to deteriorate quickly. And if you don't catch it, they can go into cardiac arrest much sooner than we would for an adult patient. That concludes our pediatrics and infants. We're going to spend quite a bit of time as far as their skills and abilities with this. Thanks, everybody.